All right, let's get started. So I've been told that I speak softly, so if somebody in the back can't hear me, please move forward. So what are the goals for this discussion? So I want this to be an open discussion kind of forum, so feel free to ask questions, and we would love some constructive criticism. How bad is it? So how bad is the situation? So the healthcare is increasing percentage of GDP with every year, and in 1960s it was 5%, and now it's in 2010 it's 18%. And the admin costs increasing as a percentage of total medical cost is, you can see how steep that rise is since mid 1990s. So seems pretty bad. So why did we end up here talking about blockchain and healthcare? So one of the main problems that we face with healthcare is that the custody of the data does not lie with who it should lie with, which is the patient, the person whose healthcare data it is. And then the data is fragmented. So if I see a doctor at Stanford, then one at PAMF, then I used to live in Chicago, so I saw somebody there, and it's all over the place. So what happens when the person who should have the custody of healthcare data doesn't have it, and it's fragmented? So duplication is a common thing. So let's say I got a blood test done 6 months ago, and my doctor wants to get a copy of that test. And I called the other doctor who ordered the test. I wasn't successful. I got through the nurse. They said they'll send it, but it never got there. So what do I, as a doctor, end up doing? I just end up ordering that test again. So, and then the data is, so there are forces of centralization that want to continue the data, for the data to stay centralized. So on the demand side and on the supply side, so basically the patients tend to go to Stanford. So let's say I need to see a knee doctor at Stanford, and I had back surgery at Stanford. I'm sorry, if I need to see a knee doctor, I'd rather go to Stanford because I had back surgery at Stanford and my data is there. I might know that there is a good doctor for the knee elsewhere, but I might just feel that, you know what, it's just better that I go to Stanford. And on the supply side, as a young physician out of residency looking at, okay, should I open my own practice? Should I work at a big place? There's already so many patients going to PAMF and Stanford and other bigger practices that I feel the force that, okay, if I start on my own, I have to do a lot of marketing. It's kind of, I have to manage all this data. I don't have this technology. It's kind of swimming against the flow. So I also might want to just think, oh, it's just easier to get a job at Stanford or PAMF. Why bother? And it's also, it makes it difficult to do healthcare research because the data is siloed. So a researcher at Stanford will get data from Stanford patients, and it would be very difficult to get data from multi-sites, and it's even more difficult to do a multi-center study. So it makes healthcare research more difficult. That's why US doesn't come up with as many health care studies with thousands of patients like Denmark does or Norway does, because they have centralized registry, or Canada does, because at least in part their data is centralized. So good research comes out of thousands of patients, which doesn't tend to happen here. So the gatekeepers of the data have no incentive to innovate. In fact, they have incentive not to innovate because information is power. Data is money. So hospitals like Stanford doesn't have incentive to say, okay, I'm gonna give you your data. You should definitely have your data. Here you go. Here's the, here's the CD. Here's whatever format, paper. They don't do that, and they're not going to do that. In fact, they're going to make it a little bit difficult and say it's going to take 7 to 21 days for us to process it, and you're going to have to pay a fee based on the number of pages. And there are going to be hundreds and hundreds of pages, and you might feel, well, it's there with them, why bother, right? So that.
I have one question.
Sure.
So have you used a Lucy program basically to share the medical records? Suppose when I go from Stanford to Kaiser Permanente or some other hospital group, they offer this on the website itself.
So yes.
Download your what do you call it, as all the medical history using Lucy program, I think it's.
So
and exchange it.
Not.
And send it directly to a doctor or electronically to the.
So they are trying to make it somewhat easier, and it is the law to provide the data to a patient and provide it in a way that is patient friendly, the way patient desires, as long as it's feasible for the organizations. So I work at Stanford, and Stanford and PAM share Epic, and in Epic there is something, there's a tab to sort of look at the combined data, but I can tell you this, it practically has never helped me, because the information I want sometimes is missing, sometimes isn't updated. All I've been able to see is some lab reports, but for other things I have to go through certain steps to kind of pull the data, and I don't know how to do that. And I'm assuming I don't know how to do that. Probably a lot of other doctors don't know how to do that. So practically, at the end of the day, it doesn't end up working. So now, the private practices, the same thing. Our patients, our data. We don't want to share it. We don't want to give it away. Labs. So if you go to Quest, you want to, if your data could be pulled and extrapolated in a meaningful way at another place, then you don't care if you go to Quest or LabCorp or PAMF Lab or wherever you go. But that's not the case. So you tend to think, well, I got my last 5 labs at Quest, so I might as well get the 6th one at Quest. And Quest likes that, right? Similarly for pharmacies, if I go to CVS is near my home, I know the pharmacist there, I'm going to go there. Health insurance companies, pharmacy benefit managers, and kind of how they interact, they don't want to share information. So those two businesses specifically are built on opacity. So they don't want to give out the data, they don't want to give out the numbers. And it's a very interesting interaction with pharmacies, drug manufacturer, pharmacy benefit manager, and SureScripts. Even my head spins when I talk about them. So pharmacy benefit managers, for those who don't know, are sort of insurance for prescriptions. So they get some part of the money that you pay for your health insurance that goes to them, and their job is to pay for your prescriptions, part of your prescription outside of the co-pays and deductibles to the pharmacies. And they own SureScripts, which is an electronic prescription method that's sort of the pipeline to all these different pharmacies. So they have a vested interest, and they control everything. They have so much control that overnight they can find a clause in their big contracts and shut down a pharmacy. And they decide the prices for pharmacies. They also negotiate with drug manufacturers, and they have the power to say, I'm not going to take your medication unless you give me this much rebate. So they're basically negotiating and benefiting from pharmacies and from drug manufacturers, and these rebates are not really going to patients. So these are kind of the big middle managers for prescriptions sitting in the center with a little bit too much power. So what happens, so how life changes when you get custody of your own data that you should have legally. Your interactions with hospitals and doctors, so no more duplicate tests. These tests are expensive. So better diagnosis, less risk of doctors making mistakes because of lack of data, and more personal health care. So it does make it somewhat easier for doctors to open their own practices, smaller or single doctor, and they tend to try to do things their own way and provide better care, more personal care. So the decreasing the forces of centralization might lead to that, and the number of doctors with the number of practices as it increases might also drive the healthcare down, because there's going to be more options for patients and more prices and kind of negotiating capability. And it will reduce admin costs. So I can tell you, my assistant probably spends at least 25% of his time trying to get records, trying to connect to the other doctor, being on hold. Then they said they're going to send it. They sent it. They said the fax says sent. It never got to us. We go back and forth, and sometimes we just give up and hope for the best. So that kind of admin cost will definitely be reduced. Then in terms of prescriptions, so lower prescription costs, especially for so it might create an open market. So a patient might get a prescription and put it up, de-identify it, put it up, and say, let the pharmacies bid, especially the ones who don't have insurance. So that would be, I would say, close to 5% of the market. And then it could also lead to patients who have insurance, but their copay ends up being higher than the actual cost of the medication. So if they're low-cost generics and they're paying $20 for a $4 medication, they might want to go online and say, hey, I'll pay cash because this medication isn't too expensive. Or people with high deductible plans. So that's a 3-4% market more. So that's a pretty huge, significant part of a huge market that blockchain can capture. So because health chain can be the trust provider. So SureScripts right now is doing that job. SureScripts owned by PBMs. So that's the pipeline. That's the kind of trust provider that says this is a real prescription from a real doctor for a real patient. So health chain can be that trust provider. And PBMs no longer remain market aggregators. They become their function would be just risk pooling. And then the effect on health insurance. So it's hard to predict because of legislation and Congress going back and forth how exactly health insurance costs might get affected, or how. But I expect this market to get destabilized. And one of the ways in which this can happen is, let's say if you're a healthy 26-year-old, you just lost your parents' insurance. You say, well, I've never really seen a doctor except for occasional physical. I am going to de-identify my data, put it on the health chain for bidding from insurance companies. And which insurance would not want a healthy person on their panel? So that's kind of one way in which at least healthy people can benefit from health chain, potentially. But if it creates an open market for insurance in general, it sounds like it might destabilize this whole industry, and I don't know how the downstream effects might happen. So, and it can also eliminate claim filing industry. So insurances can communicate with blockchain, and so what is the claim filing industry? So a doctor sees a patient, writes a note, and builds a certain code which proves the amount of work done by the doctor for which the insurance pays accordingly. So if insurance has that information of XYZ patient with my insurance, who's on my insurance panel, was seen at 1300 hours on 9th of September 2017, then and doctor coded this and this, then it reduces the risk of fraud, and it eliminates the need for going on to another system and filling in the numbers, date of birth, patient name, the codes, the date, and taking chance that with human error, some of the claims are going to be wrong, get rejected, and come back, and eliminates the need for big audits that are very time consuming, and time is money. So in that way, it can potentially eliminate claim filing, and better research, like we talked about, that you can have thousands of patients with their data, and you can realize the value of your own data. So you can have a marketplace where researchers can come and bid on your profile. So you can put your de-identified data out there, or they might advertise, we need patients between 30 and 40 who are taking cholesterol medications, have no history of heart disease, who are slightly overweight. And you might think, well, I kind of fit that profile. So you might, sell your data to that researcher for $10 and say, okay, my data has some value. So that's another way. So presence of using healthcare on blockchain, it gives people space for permissionless innovation, and allow multiple apps. People in Africa could be developing apps. People in India could be developing apps in their own language. So because what happens right now, so a lot of healthcare apps are developed. They're out there. I think it's probably within thousands, if not millions. And what happens? If you want a lot of your data on your app, then you will, for example, you start with Stanford. So if you want to build an app that communicates with Stanford's EMR, you need to go through the whole Stanford bureaucracy to get permission. Then you need to get permission from the patient himself. And then that doesn't even cover all of the data for, maybe let's say 1,000 Stanford patients who are willing to download your app. So you're kind of stuck with one bureaucracy after another. So you go to PAMF and you go to anywhere else, and how many doctors and hospitals do you chase to get a complete picture of the patient? It's impossible. So you decide, I'd rather just not develop the app, or I'm just going to develop the app, forget about marketing. If people use it, great. If not, whatever. I'll just move on to another project. So it's not like it's not been tried before. It has. So Austria has ELGA, which is government mandated. Then Google Health, which was shut down in 2011. VA's Blue Button, and Microsoft Health Vault. So what is the reason? Why don't they succeed? So Google, so people are really wary about putting their data on Google and with Microsoft, because they feel maybe it's, I don't know if I can trust them. Are they going to mine my data? So I think maybe it could be a user interface, but I think part of it definitely is the psychological feeling that Google knows everything about you, or Microsoft knows everything about you. And it's hard to get past that psychology. And then the VA's Blue Button, really good idea, but then the customer adoption was low because they need to back up their own data and figure out how to share. And I haven't come across that many patients at the VA who would be really good at doing that. So what is different this time? So why do we think this time it might work? So blockchain guarantees immutability of medical data. So medical data is one kind of data that should not be tampered with. And you, as a doctor, you need to be able to trust that data. So if a patient gives me data, even if it's written notes, I still worry about, okay, what might be missing? Is the patient trying to hide something? Because there are things that people are embarrassed about. They don't want to share even with their doctors, like their substance use or HIV status. But it could lead to really bad consequences for doctors, especially surgeons, to not know that sort of thing. Then IPFS allows decentralized storage of medical data. So it reduces latency, and it gives people confidence that sun may burn out, but this, without their permission, nobody can mine or use this data. So that, I think, kind of overcomes the psychological barrier. And the tokens enable a business model without having to mine the data. So how do you run something on fumes? So this token economy would be very important to this whole ecosystem to make it work and keep it going. Let's see. So centralization versus decentralization. So why not, use Amazon servers in different countries, and why bother with decentralization? So the benefits of decentralization are, so the cost of storage will be lower. It's easier to scale, lower latency, and then what I mentioned before. And I don't have to trust Amazon staying in business for my business to work. So that kind of is also important for the person who is starting this. And it will have, I believe, way larger impact on developing countries than it will in developed countries. So the impact is good here. But in India, the impact might be huge because there is no electronic data practically to speak of. And the doctors scribble something on a piece of paper, give it back to the patient, and the patient is supposed to bring it back. Half the times, patient doesn't know that they're supposed to keep that piece of paper and bring it back, 3 months or 6 months later, and keep those papers for years and years. So, so using this technology in the right way can have a huge impact there.
So I have a question. Google very abruptly, quickly got out of that application they had. Do you know the real reason? Because they had the money, they had the capability.
They put.
It was like they said, "Oh, we are getting out." What was the reason? Because, they have the technical capability, the money. What they didn't see, or they did see, that made them to decide that.
I don't know. My best guess is that it partly, at least, it's psychological block about that. But I mean, if anybody here has a better idea, please feel free to share. But I don't know. Go ahead.
I think that the reason was people was like looking data and getting their own advices instead of going to doctor. So they were like doing it by their own, and that was not the intent of the people. So, and they couldn't figure out how to stop this, and so that's the reason that application basically shut down the whole thing.
So Google was worried about litigation, that if doctors, people stop going to doctors and just manipulate.
Because people started like Googling things and finding out what.
But people still do that. Like everybody I see.
But it's not a product, right? Google is not offering that as a product right now. Google search is not doctor like product for that. It's on your own risk.
I think that most people don't keep their test results and test data in their possession. It's a doctor thing, it's the lab. So I think the company that is closest to getting to like a massive health record, online health record is Epic, right?
Right.
They are a monopoly in that space right now, almost a monopoly.
Absolutely.
And they are starting to connect the dots between Stanford and
I can tell you at this point, at least, they're not doing it very nicely and smoothly.
Right.
So it's I have rarely found it practical. And the other big problem with Epic, the reason that I didn't want to work at Stanford partly was I would have had to use Epic. I did not want to use Epic because Epic is heavily dependent on verbose notes. So you write words and words and words and words, and then the next appointment you're filtering your own words to try to remember the important information. And you write so much because you want to make insurance happy, so you get reimbursed well. So the focus is on making sure that I get paid properly for the work I'm doing, not that these are the most 5 important points I need to know about this patient.
I think what happens is that this is exactly the issue that we have is that there are many players, and in order to get reimbursed, you have to fill out a detailed report of the patient, and then the test results has to attach to that. And if you don't do it well or on time or something, then you don't get reimbursed. So there is a lot of regulation.
Yes, I know all about getting into trouble for that.
Exactly.
That's not Epic's fault.
No, well.
No, it's the regulation. There's huge regulation, many players.
But that takes
the example of the dysfunctional family that you were talking about.
So yes, the relationship with insurance is really like a dysfunctional family, which is dysfunctional in their own equilibrium. And if you shake the equilibrium, no matter how dysfunctional they are, they don't like it. They want to keep going back to that dysfunction. So this is kind of the inertia healthcare is also stuck in. It's like a dysfunctional family, the insurance, the pharmacy, the PBM, the doctors, the patients, and it's hard to shake that equilibrium and not get backlash and to succeed with some sort of change and get them out of this inertia into a functional equilibrium. So so we are stuck in a rut, in short. Did you have something to share? It looked like you wanted to say something about Google Health. No, behind you.
Oh,
Yeah.
Oh, I was just saying maybe it's some sort of FDA regulations related.
Oh, okay.
I guess the entire ecosystem needs to come up at the same time.
And right, exactly. This whole ecosystem is happy in its dysfunctional equilibrium. So why blockchain? Why? It's possible. There is technology that most of it, if not all of it, can be done without blockchain. So we need to have immutability of medical data. So we have digital signatures, but on top of that, we have ordering that's guaranteed by blockchain, which is important for medical data. It's important that when you started Cymbalta, before that your liver function was X, and now after 3 months of being on this medication, your liver function is 2x, in 3 more months it's 3x. So it's slowly going up, and it correlates to the fact that you started a certain medication that can affect liver function. So just data is not important, meaningful data is important, and with blockchain we can have that. And blockchain also enables a token-based business model. So why tokenization? So can we do it without tokens? So token enables creating the network effect, and to shake this dysfunctional equilibrium to get people out of that inertia and create a network effect, I think tokens would be very important. And tokens have value if they're backed by the real business. So what is the real business here? So the exchange of data between different health entities. So I want data, Stanford has it, or I have data, somebody else wants it. So that kind of exchange, or patients having their own data, because it's if you have ever dealt with multiple doctors in multiple locations, and doctor asking you for your data and you not having it, and then doctors trying to get it but not succeeding, how many people have kind of gone through something like that? Okay, so you have, I have, many people I know have, so that's one way, so sure, go ahead.
Why do you think healthcare data needs to be immutable? And also, what if you make a mistake and then your healthcare data is the mistake you made in putting in the record is now immutable? So
the healthcare data can get updated. It needs to be immutable because people might try to hide things, like it's very important for a doctor to not be actively addicted to substances. Or if somebody is going to have surgery and they're HIV positive and their surgeon doesn't know, because they want to hide that HIV status. So that would be a very bad idea. So that's why the data needs to be immutable. So if somebody is giving me data themselves, so if patients are giving me data, I always, let's say they're on the phone and they're saying, I have this list of my lab tests, and my AST is 40, my ALT is 50, my sodium is 139, and I'm at the back of my mind, I'm writing it down, and I'm worried whether they're reading it right, or is the date right. I am worried that what if they're making a mistake. And it's not because I think patient is stupid. It's because humans can make errors, and I would be paying for that error later. So I want to be sure that the data is correct, and it's very, very important.
So I think there's a point on that. You are looking from a doctor's point of view, but if you look at from patient point of view, a particular set of records may reflect that doctor's view of that patient. And if that patient wants to start fresh, having a set of records that will always direct the next set of doctors may not be something you want to have. So, there has to be some capability other than
So
just
you can
adding
always
additional information to purge some of that information.
I think yes, it would be one of the practical
Because
challenges.
at the end, it is your data. If we truly believe that it is your data, you should be able to purge with the full effects.
That is true, and I think that's kind of a practical issue that we are going to come across, and I think we'll deal with when we come across it. But you do have a point, and it did cross my mind. What if the patient doesn't want to share specific things in that situation? So part of it is relatively easy. If patient wants to start afresh, they can start afresh and not use their health chain data. But the other part of it, where they want to use the health chain data but not use some of it, I think is probably a practical problem we'd have to give more thought to.
You give flexibility to the owner, and allow them to decide.
Maybe limited flexibility.
So I just want to mention that in Austria, they have this system called ELGA, which is a centralized system. And what they have done is they have allowed something called situation-specific opt-out. So in case of an abortion or a psychiatric diagnosis, the doctor has to actually inform the Austrian citizen that, would you like this data to not go into ELGA? And in other cases, patients can actually choose to opt out. They can tell the doctor that I don't want this data to go into ELGA.
But that has to come from the patient. But in certain cases, it comes from the doctor, that the doctor has to get the permission of the patient before putting that data on. So I think that, that's actually, I forgot about that. That's a good point. The challenges that we anticipate will face is getting the early adapters to jumpstart the network effect. Getting machine parsable data that's not just PDFs, because if somebody gives me a huge amount of PDFs, I would feel the same way I feel looking at notes in Epic. I'd kind of roll my eyes and skim through it really fast and hope that I got everything and cross my fingers. The current players are not going to give in easy, so there will be resistance at every step. Every market that it potentially can destabilize will put up a resistance. One of the big markets that we anticipate might put a resistance is the pharmaceutical. Because the legislation says prescriptions can only be sent to a patient or pharmacy. They can't be sent to kind of a space where pharmacies can come and bid, right? Once the data is in paper format, it becomes high cost. And a lot of doctors still kind of communicate in that and use faxes. Everybody uses faxes. I call myself more technologically savvy doctor, but I fax, and that makes me feel very embarrassed about it. Pharmacies cannot lower the prices of medications because the prices are determined by the PBMs. PBMs can remove a pharmacy. So if pharmacies decides that's fine, I'm going to try to capture the uninsured market, PBMs might find some clause in their big stack of contracts and say, no, you're done, your business is done, and they have that power. So maybe one way in which PBMs can be circumvented is if there are new pharmacies, new business opportunities that come up just on health chain, and they directly communicate with manufacturers, so they cut out a lot of middlemen and only sell prescriptions on blockchain, on health chain, and that kind of return, so the advantage of that comes to the patients, and that will be one of the advantages of being on health chain. So and then the other part of the market is if the copay is higher than the cost. So the breaking the inertia, so giving tokens to early adapters, delivering pharmacy savings, the lab results. So if you kind of make meaningful data out of the lab result, and you kind of are able to meaningfully extrapolate it, and the patients like it. So HL7 is the universal language that these EMRs are supposed to communicate, and it's an industry standard. And then you would be able to share wearable data with your doctor. So sleep is, like, for example, a very important topic for my patients, and a lot of them track it, and they kind of tell me their own judgment, but they can't share that data with me, and I can't compare that data with, let's say, if I prescribe somebody Ambien and their sleep actually got worse than better, and then I prescribe melatonin and then something else. It matters to me because I'm prescribing medications for sleep, but they are the only ones who are looking at that data. So it would be nice to be able to meaningfully look at that data. And then create research marketplace for medical data, so patients can realize the value of their own data, and create correct APIs to enable app ecosystem, so permissionless innovation. So when would I know that we have succeeded? And I would know that when my patient tells me to send their prescription to their health chain account. So I'm still sending it to the patient, so but on their health chain account. When my patient tells me, hey doc, you can get my history on health chain. And next time, instead of reordering an expensive test, I get the previous results pretty quickly, like that. Because that's all the time I have. I have this much time to make a decision of how much time to spend trying to get their data. And I get flyer in the mail offering me lower health insurance rates, like people get for credit card. And my next prescription is being filled by pharmacy in an where I accepted a bid from an open market for the lowest cost. And the year I earn $100 for my de-identified medical data from health researchers. And if I am able to do my research study and find 1,000 patients matching that criteria for which I want to do the study, without waiting 6+ months, just like that. So I would really care for that. Basically, those are the thoughts I wanted to share with you, and feel free to ask questions. Thank you.
You mentioned something, early adapter. What did you mean by that?
So people who get on the health chain earlier, the people who start open their account and start using it, get their data on there, start using it for prescriptions and just in general their healthcare data.
So patients, doctors, who?
Patients and doctors, actually. So so the EMR interfaces, so the apps can be built onto the data, right? So you can build on EMR interface, and the doctors can get on there, and they bring on the data to health chain, and so do the patients. So those would be the early adopters.
Our understanding is that doctors are like chickens running around with their heads cut off. So when you actually go meet a doctor, they're so rushed for time that asking them to do something new is very difficult. It's like expecting them to do something new is setting yourself up for failure. So at the end of the day, I was listening to the chief technology officer of the Department of VA, and he was saying that in today's world, if you go and ask a medical facility for your data, it's like going to the bank, asking them for $20 in your bank account, and first they ask you, why do you need the $20? And then you tell them, maybe you're in a good mood that day, and you tell them, oh, I need to pay my rent or something. And then they say, okay, we'll send it to you in 7 to 10 days, and guess what? You gotta pay me $2 for the privilege of getting access to your $20. So that's how the health industry is. And another very good point that everyone makes is that if your business depends upon not being able to do something, you will not be able to do that. So today, Epic's and everybody else's business depends upon making it hard to be able to share data. So whenever you go and ask them, can you share the data, they'll say, oh, this is very hard, this is very difficult to do, and so on. But that is because their business depends upon keeping that data to themselves. One good example is that in 1857, Pennsylvania, the town of Erie had a 6 feet gauge for the railway tracks, and the other towns had 4.5 feet gauge. So in the town of Erie, a lot of people had a lot of jobs taking stuff from one kind of rail car, putting it in the other kind of rail car. And they found reasons, very good reasons, to never make it a 4.5 feet gauge. So I think the only place from where this dysfunctional ecosystem can be made better is because for approximately 10% of us, I'm one of them, I suffer from sleep apnea. It's very important for me to give my sleep data to my doctor, but I'm not able to share the sleep data with my doctor. So there'll be 5 to 10% of us who suffer from difficult conditions, and they want to share their data with the doctor. They will start using an innovative platform where they'll take ownership of the data, and they'll put it on a neutral bus and share it with their doctors. That is the beginning. But I think there's a lot of inertia, and a lot of people in this industry actually depend upon not understanding how to do this right.
Yeah, so I know you mentioned something about being able to share your data with people who have tokens and enabling that sort of research. But I think, at least from my background, privacy is an ever-growing concern. So how would you envision how people can actually control that access?
Sure. So so this is just a research project. It's not something that we're doing actively. But I'll describe to you a demo system that I made. So there, what I do is when you come to the website, you enter your password. By looking at that password, we generate your public key and private key, and it's all done in JavaScript. So your private key always just remains on your browser. It's never sent to the server. And the public key has a one-to-one relationship with your username, which can be @something. So I might decide to be called @Vikas because, or if I say if I want to remain private, I might call myself @Silicon Valley. So you get to choose that @. So there is no real name policy. And now if a researcher wants access to data, our hypothesis is that lives are busy. Nobody's going to go and be able to look at all research requests for data. So they'll say things like, okay, if it's a nonprofit wanting to get access to my data, give it to them for free. If it's for profit, I at least need $10 for my data. So the algorithm internally will start sharing the data. And the way it will work is, as a researcher, I will take your public key because it's public, and I'll encrypt my data with your public key and put it back on the IPFS decentralized storage space. And I'll basically inform you that, okay, now you can access the data. You will download the data to your local computer, and you'll use your private key to decrypt the data. So though it's PGP, but we try to take care of the UX problems.
So it's like you create groups, and within the groups, people can say, I want to give this group access. And
Yes.
But what about HIPAA? Is there HIPAA?
So HIPAA has been made to protect the privacy of consumers' data, and I'm of the personal opinion that it's being abused by some players in the industry because data is like the oil and it's good to guard it. And one of the reasons you can say is, hey, 6 feet gauge is better than a 4 feet gauge because my jobs depend on it. So HIPAA is slightly being used for those reasons to protect their own businesses. In this new world, if I have access to my data, if I own my data, and if I want to make my data public, it's my data. I don't think I'll I'm not a lawyer, I'm not an expert on HIPAA, but I don't think HIPAA should stop me from doing that. And I think, like today, I work in a clinic. I'm a CTO at a clinic, and the HIPAA protection at our clinic is that the place where the fax comes in, it's behind a locked door. Believe me, a PGP system, data being encrypted by the public key, is going to be so much more secure than fax has to be accepted behind a closed door.
Okay.
So you're going to have decentralized system for this, right? So are you going to have miners for this?
No. So the idea is, and again, these are just ideas. So the idea would be that, say I want to share some of my data, right? I told you I suffer from sleep apnea, so there's a data that's being uploaded by the mask that I go to sleep with every night. It will upload the data onto the IPFS file system, and it gets a hash. Every time the data is uploaded, it gets a hash. It's only that hash that's written on the Ethereum blockchain. So what happens is that it can now be verified 5 years down the line that this hash has not been modified, right? Because to modify this hash, a lot of things have, like SHA-256 needs to be broken and so on. So only the hash goes and lives on the Ethereum blockchain. We don't think we need to create our own fork of Ethereum because we are not innovating at the protocol level.
So you said you were doing a lot of research. Do you have any GitHubs, open source? Is it all? Is some of your work? Because I've had a hard problem finding open source experimental.
Sure. So yeah, I think if you go to github.com/healthchain today, you might see some code there.
Okay.
I'll tell you guys the biggest problem. The biggest problem is the bottom line is most of us consumers, we are happy being taken care of. The world has taught us to live in a nanny state where the nanny state takes care of us. But the reality of it is, don't quote me, don't ask me for a reference right now, but I heard the CTO of the Department of VA speak a couple of days ago, and he said, more people die in America every day for medical errors being done because there is not enough medical data available to the surgeon operating on the person than people who die from cancer, car accidents, and 3 or 4 other things combined. So though, we like to live in a nanny state, we say, hey, it's the doctor's problem for me to be fixed. And if I don't get fixed, I'll go to the lawyer and sue the doctor. But I think there'll be a small percentage of people, 4 or 5% of people who will want to own their data, and they'll be the agents of change.
So I guess my question is it better to go closed source or open source with the strategy?
I think definitely open source. Definitely open source. Because I personally, I remember back in 2010, I uploaded my data to Google Health, and then I was sleeping one night, and I woke up and I deleted all my data from Google Health because I was worried that, hey, Google's going to now know that I have sleep apnea. Next time I apply for a job at Google, I'm never going to get it.
No, he's never going to come on time.
Yeah. So it has to be open source so people can verify that it's being encrypted properly and so on.
What prevents someone from buying my data and then turning around and selling it?
Absolutely. So once somebody buys your data, they get access to the data because you encrypt it with their public key and then make it available to them. So there are 2 things that prevent them. One, the data is de-identified, so even if they sell it, people are not going to recognize you. And the second, the community is going to know that, right? And hopefully in future they'll never be able to do the same thing. So what happens today is that your data that has Stanford, there's a nice loophole in the law, and the nice loophole in the law says that Stanford can actually sell your data as long as it's de-identified. So your data is still being sold. It's just that Stanford's the organization of PAMF or El Camino Hospital or Epic. These are the guys who are making money from your data, from your de-identified medical data, but in future, hopefully the consumer will make that money.
Yeah, I think it would be interesting to see if you can incentivize the adoption by consumers, considering we live in that family state that you're talking about, by taking I don't know if the Uber route is the appropriate one, but figuring out a way of having the consumers benefit monetarily, financially.
Absolutely. So consumers. So one of the things that Dr. Savant says to me is that the biggest problem is that people are not willing to take responsibility for their own health. Because believe me, I would do much better standing in front of you guys here if I went to gym every day. But I don't go to gym. I know I'll do so much better if I went, but I don't because
In Russia.
In Russia. So, yeah. So I think the biggest place where benefits can be delivered is pharmacy savings. It's like Dr. Savant can talk about it more, but how incestuous the pharmacy market is that it actually makes you feel like, oh my God, which country am I living in? Where there are companies that make billions of dollars and whose only business model is to hide data.
So, interestingly, an example I'll give you is, you will get explanation of benefits from your insurance and PBM. So, they will say this medication was for $400 and we paid $360, you paid $40. And you did pay $40, but if they saved $360 for you and you paid $40, but that's $400 is not the price of that medication. The manufacturer does not tell anybody how much they made it for. The PBMs tell the manufacturers, give me this much rebate to get this medication on the formulary, and the PBMs decide this is how much the pharmacy is going to sell it for, but $400 was never the price of that medication to start with. And nobody knows what, I think at the end of the day, nobody really knows how much that medication really cost.
Yeah, I think if you took the top 100 medications in America and you tried to find the actual price of that medication, I don't think you could, for 90% of the meds, you will not know the real price.
Canada, you could find out.
Yes. I think everywhere else you do find out what the market price is.
So between the drug manufacturer and the pharmacy, say CVS or Walgreens, what is the role of PBM? What is the economic role of PBM?
Oh, absolutely. Very good question. You want to take that?
Go ahead.
So the reason why PBMs were invented was to have this idea of risk pooling. If all of us here each month gave $50 to a PBM, so that if one of us got sick and needed a $1,000 medication, all our money is being risk pooled at this PBM, a pharmacy benefit manager. So that's the role of PBM. In the economic terms, they are the guys who pool the rest.
Insurance.
Basically, insurance for pharmacy. So when I pay to Blue Cross, my health insurance company, $2,000 for a family of 4, it makes me very angry every month. And largest expense in our family. They turn around, they take around $400 out of the $2,000 and give it to a PBM. So they actually outsource the pharmacy risk pooling to a PBM. That's what they were supposed to be.
Okay.
But what they have become is a market aggregator. What they have done is that they now turn around to the pharmacy and tell them, hey, you want to sell medicine to Vikas? Then you got to do this for me if you want to sell medicine to Vikas, because otherwise I'll tell Vikas that your pharmacy is not an authorized pharmacy. And if if your pharmacy is not an authorized pharmacy, then Vikas doesn't have to pay only the copay. He has to actually pay $400. The total inflated max MRP of that medication, which has been inflated so much because there's this back channel called a rebate. I come from India, we call it bribe there. Here they call it rebate. There's this back channel called rebate, which is like, okay, the med sold for $400, I pay $40, and somehow $250 is being paid by the manufacturer back to PBM. So it's a big mess.
And PBMs also hold it over the patients. So have you ever heard about a prior authorization? Some doctors put it on their website, will not do prior authorizations because PBMs decide that's not a medication the doctor should prescribe. They should prescribe this, or this first before they prescribe that. Even if the doctor knows that this, and this have similar side effects, that's probably not going to work. The patient's going to suffer for another 3 months and maybe stay disabled because of depression. But I have to go through those steps to prescribe, to get to that 4th medication that I really think I need to prescribe.
And I got to tell you industry secret. Dr. Savant has been in the industry for 15 years, and she tells me once in a while, she has to have a couple of glasses of wine, but she tells me that the PBMs will go to the manufacturer and they have a list called the formulary. A formulary is a word which basically means that these are the medications that Dr. Savant is allowed to prescribe. So they go to the manufacturer and say, hey, do you want to be on my lucrative formulary? And the manufacturer will say, oh my God, I really need to be on your formulary, because if I'm not on your formulary, then the meds are not reimbursed by this risk pooling entity, the PBM, and they basically extract benefits from the manufacturer. They say, okay, if you want to be on my formulary, this is the list of demands that I have.
And if you're not on the formulary, then the patients end up paying more, so the patients go, well, I can't afford $100 every month. I'd rather get the medicine that costs $20 every month. So,
and something that should make all of you very angry, that in 1997, what they all did was that they lobbied the Congress and said, what we really need is a way for doctors to write electronic prescriptions. So the prescriptions go directly to the pharmacy. So we'll create a company called SureScripts. But guess who owns SureScripts? The PBMs own SureScripts. So the great thing is when Dr. Savant, so when I go see her and I say, Doc, give me my medication, and she says, where do you want me to send it? I say, Costco in Mountain View. And at the back of my head, I'm thinking, damn, man, I'm sure Walmart in Mountain View there sells it cheaper, but there's no way that I can tell her, okay, send it to Costco and also send it to Walmart. And
you can say it, but I might say, you know what, see another doctor.
See, yeah. Like, where is cheaper so I can get a cheaper medication? So they've removed all the competition from the market. And PBMs together are a $1 trillion industry, so changing it is going to be pretty hard.
Okay, my question is, you mentioned HealthChain, right? Is HealthChain a platform that can be used right now? Or
oh, no. HealthChain is basically something that we talk over coffee. So the difficulty is so huge that to even take it on seems...
It has to be done with some... It can be started. I think it's a very practical idea. It's not one of those things that we just talk about and will never be done. It's going to be done by us or somebody else, but it's going to be done because I think time for it is now.
Any developers? I know there's a bunch of them out around here, right? Because the second part of that question is, you mentioned that a patient's records will be uploaded to the blockchain, allowing buyers to buy those records for data research, correct?
Yeah.
If I, the patient, did not want to publicize my records, is it possible to keep that
Definitely,
private?
yeah, that's totally...
Me and my doctor?
Yeah, totally.
Absolute control.
But it sounds like there would be no reward system of token, right? Because that's very...
So again, this is something that we think about. What we think about is, imagine a world where there were 2 billion health coins, and I've been developing software for 25 years, and I can do an ERC20 token by the time I leave here and get home. Yeah. So I do a 2 billion health coins, and I say, take 1.6 billion of those health coins and give it to a foundation run by 3 professors from Stanford, 1 economist, 1 computer science guy, and 1 medical guy. And their only job with these 1.6 billion tokens is to take on these entrenched interests. And then I'm sure those economists, they might say, okay, the pharmacies would be interested to read and write, to be able to, will want to find prescriptions on this health chain and be willing to bid on fulfilling that prescription if there were at least 1,000 prescriptions on this health chain every day. So they might say, how do I get 1,000 prescriptions on this health chain every day? So they might say, I'll give 5 health coins to people who start using it to upload their prescriptions till the time I get to this 1,000 prescriptions every day, because it's like the first step of creating the market, creating the demand side of the market, and then creating the supply side. So those are some of the ways in which the market can be bootstrapped and can be ignited to begin.
You had a question earlier, I think.
I have a question about the business behind the chain. So currently, I know the problem of decentralized software in the iPad, but they do that because they can make a profit selling the software license. But for this kind of decentralized chain, but what is the business behind?
Absolutely, very good question. So let's just take this idea of 2 billion health coins out there, right? So first of all, how will I make money? Because I got to afford a home in Mountain View, very expensive. So if there were 400 million 2 billion, I'll say 20% is for the founders. So who will be the founders? Founders will be all of us because we came to the first presentation. So founders, founders. I'll have to take a picture from here so I remember who are the founders are. So, but the founders will have 400 million health coins, so the founders make some money, right? And now for the other 1.6 billion health coins that's being used to bootstrap the network, what you do is finally, when the network is bootstrapped, right, some researchers will want to buy some of your data or like other people's data. So maybe they need to pay 10 health coins. When they pay 10 health coins, maybe one health coin, maybe 10% of it goes back to the health chain foundation. So basically, whenever, and suppose Samsung watches and all their wearable devices, they want to put data on health chain. They pay some health coins to be able to put data on this network. So just imagine this, TCP/IP. TCP/IP was a protocol that connected computers, but none of the money was kept by the guys who wrote TCP/IP. All the money was kept by Google, Facebook, Twitter, these guys, the app developers. But tokens enable a business model where the guys who make TCP/IP or the guys who make the health chain protocol can also afford homes in Mountain View.
Okay, my question is Stanford actually looking to start developing a program for this, or is this just a research that you guys are presenting on?
Sure. So Stanford is a big bureaucracy, and but the good thing about Stanford is that it's very decentralized, and they let you just go ahead and do anything you want. So Stanford as an institution is not involved in this today.
Okay.
Just out of curiosity, quick question over here.
Sure. Because
Yeah.
Who do you go to for that is the #1 expert for blockchain healthcare? You know, who's been working on the longest? Who
Sure.
do you go to, basically? Personally.
I don't think we should even be looking for that person,
Okay.
because the market is fluid. And the healthcare market is so complicated that if somebody says he's an expert, then I would stop listening to him. I think the right person would be someone who says, I know a little bit, seems like these ideas will work, but yeah.
I mean, the greatest change probably will come from the outside, not the inside.
Absolutely, the greatest change will come from outside. Yeah.
But however, my question is, who in the industry has been, do you know that has been working on this problem for, I guess, the longest, like, person?
So I personally, I personally know Dr. Savant, who's been working for 15 years to fix healthcare.
Okay.
12 years ago, she said, Stanford sucks, Altamira Hospital sucks, PAM sucks, everything's bad. I'm going to do my own startup called Savant Care. She did 3 years of Savant Care. I wrote, and me and my team of 10 people wrote 1 million lines of code. And then she says, the whole ecosystem sucks. And then she says, like, we got to fix the ecosystem.
I guess it's more of a question of perseverance. Who has tried and tried in the industry?
I would put my bets on this lady.
he keeps doing that, embarrassing me.
Well, I think what you're going to find,
We have
though,
5 minutes left.
when you look at this problem to solve, there's a lot of use cases that I've been listening to, like healthcare, where everybody knows it's messed up, but nobody can stop the inertia. It's like a vicious cycle. And it's because a lot of powerful partners have centralized control. So a lot of what happened at the beginning, right, in 2008 with all the banks. If there is an agreed upon issue, sooner or later you're going to find the momentum. And I think the key, and what I've seen in a lot of other use cases, is the key is the token. It starts the ball rolling.
Yeah.
It may not be the ultimate, and it's not necessarily meant to make people rich, but it provides the impetus.
So I agree with you that to break the inertia, the most important aspect is to understand the psychology of inertia. And the only thing that really breaks the inertia is instant satisfaction, instant gratification. And that is what this token economy, pharmacy savings would provide.
So the question is the timing right? Do you think the timing's right? I mean,
hard to say. I think the time is coming. I would say somewhere, but within the next 10 years, the timing will be right.
I think it's a little early. All infrastructure with Ethereum, with IPFS, everything is not there yet to even put this, you know.
No, I actually.
I mean,
Sure, if you actually go to, I booked the domain healthchain.global /my-v2 right now. You can actually log in with a password. It will generate public key, private key. You'll be able to upload files to IPFS, and so it's just a. But yeah,
it won't scale. I mean. the scales are like anything.
I heard that there's a petabyte of data on IPFS. I might be wrong, but
Okay, but the speed and everything, it won't scale. It's not there yet. The infrastructure's
Yeah,
definitely not
but-
there to even try.
my opinion is that technology problems can be solved. It's the human problems that cannot be solved, or they're more difficult to solve. Tech problems, I think, you know,
Of course.
they can
The
be
political
solved.
problems. Yeah.
Political problems are more difficult to solve.
Are you going to the ICO shortly?
The ICO.
So, see, it's very important for me and for Dr. Savant. It's her reputation on the line if she does an ICO. There's a lot of snake oil work happening in ICO, and it's very important that we don't get categorized as that, because you know, nobody knows me. They'll not know me a year from now, but people know Dr. Savant, and so we are meeting some people who we trust a lot, in asking them if we should even we should do an ICO or not. But if we do it, we just want to do it right. Do we have a decision today? No.
So you prefer to have someone running prototype first?
Yes,
Have
have
some
a
like initial
prototype
users.
first, have people use it, and see what the response from the community is. I just don't want to be called the snake oil salesman.
Yeah, yeah.
All right, 7:57. So I think time is up.
Thank you very much.
Thank you all. Thank you. And thank you.